Test 1 1, test 1 1.
know Todd, though. Yeah.
Like his daughter really like.
Please keep sending, because it really does.
I'm going to start. We have a quorum, so I'm going to call the meeting, Finance Committee meeting to order. And the first item we have is, I don't think we have any citizens sign up.
No citizens.
No citizens. So item number 3, approval for the minutes.
Move approval of the minutes.
Second.
Any discussion, comment? If not, all in favor?
Aye.
Or opposed? Motion passed. Item number 4, the CFO report. Ms. Sharon Clark, welcome. Good morning.
Okay.
I just have a couple of items on my CFO report today. You do have the June 30th Hilltop investment report on the portal. Just as a reminder, Hilltop comes once a year and speaks to you about the annual performance. I think they'll probably be scheduled at the December meeting. So we do provide you with those quarterly updates, though. The other big item that we have coming up is our budget presentation to Commissioners Court. We're going to take this next week and have some individual briefings with the commissioner and the judge if they choose. And we are scheduled on Tuesday, September 6th to present the budget. As a reminder, that is about a 5 to 10 minute presentation that I give. It is very brief, and the approval will come at a later Commissioners Court meeting, usually the 3rd or 4th week in September during the county budget approval. So it's usually a non-event, the final approval. So the time that I have with the commissioners is usually just that one presentation to introduce the board-approved budget. It is Tuesday, September 6th. We'll make sure to get that on your calendar. Yes, ma'am.
Pre-meeting before that, right?
We always give the commissioners the opportunity to meet individually with Dr. Duncan and myself just to see if they have any questions. This week, the commissioners were, quite a few of them were out of town. And so those will probably occur next week.
If we have more board members show up, would that cause a quorum, or do we need to worry about that?
It could, yeah.
It could.
Yeah. So you mean at the commission?
There's no reason.
At the commissioner court.
Yeah.
Because you're not meeting, so you can sit in the
hear.
audience.
So I know DT, you've expressed an interest to be there that morning. And Dorothy, you sounds like you may come as well. But
I'll be
there's
there.
really no reason that you have to come to that meeting as a board member. I just was telling you kind of a FYI.
Well, okay. I asked my questions on that before Commissioner's Court presentation on kind of that one-on-one. Mm-hmm. Are you able to, or can you throw in a left hook to explain the impact when you affected our tax rate last year? I mean, what the impact it was on our budget. I mean, if it takes place, I don't want them to look at our budget and say, oh, the pot of gold. That's just.
Are you speaking about the tax rate reduction from about 4 years ago?
Yes.
Yes. If that comes up, I know what a reduction in tax rate would cost JPS. So.
Okay, just I just want to get it in. You want us to build these buildings, but you don't want to give us the money. So
There hasn't been to date, at least to my knowledge, any discussion with the commissioners that would be a possibility. We all realize that there is an upcoming bond program that will have significant operational expenses attached. So I do think that the commissioners realize that those ongoing bond projects will require funding.
hopefully.
Any other questions?
No, just best of
Okay.
luck with that meeting.
All right. I'm going to move on to the financial report for July. The July report is really our volumes did not change a whole lot from June. You can see that our admissions continue to be under budget, but we do have an increased length of stay and an increased case mix index from a patient acuity standpoint. From an outpatient look, our ED visits are pretty constant with last month. Our urgent care continues to have recovered volumes. You can see on that bottom left graph, they're significantly higher and have remained so than prior year. And then in our primary and specialty care visits, primary care was down a little bit. If you look at the month of July, it had fewer calendar Monday through Friday days, so that was the largest impact that I could see. And then our specialty care clinic visits were right on budget.
The last meeting, we talked about having the ED department give us some presentation. Have we set that up for quality or something yet?
That's on my notes for the next quality committee meeting. As we talked about, I think the discussion was around left without being seen rates and some of the new processes that those subcommittees are implementing.
Okay, so it's in the work. Okay.
It is on the radar, yes.
And
for the
I
next quality.
also spoke to Steve, the chair, about making sure that move forward on his agenda.
Oh, I see.
Okay?
Steve, the other Steve. Right?
Yeah, the other
Okay. All right, thank you.
For surgery stats, you can see that our inpatient cases have remained pretty constant the last quarter, and our outpatient surgeries, again, impacted mainly by the number of weekdays in July, but still remain strong. Behavioral health has not really any significant changes. Our patient days remain constant. The clinic visits, again, a bit of a dip in July due to those working days. And then our ED visits were fairly constant over the last quarter as well. And then when you look at our other metrics, our FTEs per adjusted occupied bed continue to be favorable from a worked and paid hour standpoint compared to a 6.1 budget. When we look at the income statement, you will see the impact of the premium pay that we continue to incur as well as contract labor. So we do have favorable worked and paid hours, but the rate of pay has escalated, especially since this January. And our connection enrollment had a slight increase, but remains constant with June. So when you look at the income statement, this month, the medical center had a negative impact compared to budget. We finished the month with an operating margin of $3 million compared to a budget of $9.8. Again, that entire impact, if you look at the center of the page in salaries and contract labor, very significant overages there, even though our worked hours are favorable to budget.
Hey, Sharon, can I ask you a question?
Yes.
Back a slide. Why were the Medicaid cash collections so dramatically higher in June than they ever
Thank you
have
for
been?
pointing that out. I skipped right over that, even though I had made a note yesterday. So if you remember the CHIRP program, which is a supplemental Medicaid program that passes through the Medicaid managed care organizations that we work with, they are just now catching up from the beginning of the year. That program did not get approved until end of March.
Okay.
So we're having to reprocess those claim by claim to get that in there. And you'll see one today actually requires a modification
Okay.
to the managed care contract in order for us to go ahead and get those payments
Any
passed
doubt
through.
that we'll collect all that?
No.
And when do you think we'll be back to square one, back even?
So we've accrued this. There's not any financial impact to the cash distribution and the way that we collect it.
Okay.
But I would imagine that we've got about another 60 days, especially with the passing of this managed care contract today, before we'll be completely wrapped up. We do feel like by September 30th, when we close our year, all of the accruals should be out of there, and then we will just normally be processing claims.
Okay, thank you.
Great question. So back to the income statement, you know, we are holding on some expenses. You can see that there are some savings in some of our other operating expense on the left side. And then on the right side, our year-to-date, we are profitable at $65.7 million for the 10 months into July. We do have 2 more months left before we wrap up this fiscal year of 2022. A claim had a favorable month. Most of that is driven by the volumes that they have. So at the top left, we look at billed encounters for the month, and they were about 4% ahead on their billed encounters. Year to date, they're really break even to budget on their volume. So they've been very consistent through the month. You can see the blue line is actual, the red line at the top is the budget expectation. So from a claim standpoint, again, these are doctors that are seeing the patients that are within JPS clinics and see the majority of our patients inside the hospital. They have, again, favorable operating revenue, the top line there, due to that 4% volume increase. And then you can see that from an operating expense, they have a slight savings at about a 3% under budget. That, again, has produced a favorable outcome to budget of about $1 million. And year to date, again, 10 months through, they're at a favorable to budget of about $10 million.
UT, can I ask one more question? On a claim, Sharon, we make the statement that our purchase services were favored by 36% because we transitioned from external providers to internal staff.
Yes.
Can you tell me what services we've transferred to internal staff?
So there are 2 mainly. Neurosurgery has transitioned, and then we have some other external providers that we, there may be 1 or 2 physicians that were supplementing a service that have moved into an employed status. It may not be the same provider that moved to employed, but we've been able to hire someone and not pay that through the purchase service third party.
So that was a budgeted transition. That was a contemplated transition.
Maybe not budgeted, or we wouldn't have the actual variance, but the opportunity presented itself and we were able to recruit those specialties to where they were employed.
Yeah, I guess my bigger point is that if we're able to transition folks from external to internal and it allows us to save money, you know, the concern then goes back to the overall budget impact of overtime and premium pay and all the other elements that come with it. I guess I just want to kind of stay up to speed with you on how we're transitioning those opportunities and what the net impact is going to be, because I think there's probably going to be more interest in the other direction. I think there's going to be more interest in privatized services over the next couple of years. And I just want us to have really strong financial metrics that illustrate the net impact of those transitional changes. And I think we almost to the point that we probably need to start creating some reports to illustrate that, because I hear it and a lot and a lot and a lot, and it's coming. And I just don't want us to be caught in a circumstance where we're not able to empirically, you know, validate our decisions based on this transition, especially when it's going to internal instead of to external.
Right.
Thank you, Sharon.
Let me ask you this, just for procedural stuff. Is that part of finance, or is that part of planning, or is it both?
Well, I think where we need to focus on that is maybe having a subcommittee to address the patient issues, managed care. Hold on, let me. Hey, Roger. Yes, Roger, I'm in the middle of the meeting. Can I call you back? Okay. I'm sorry, I'm trying to cut him off. Remember, I'm trying to cut him off. I'm thinking that when I rethink about looking at planning, I'm thinking that should be more of facility and the bond program. I don't have a committee that is addressing what we need to address. So I talked to Dr. Duncan, and maybe the same way we did the ad hoc for the bond program, let's set up something a little bit more focused and have a committee, a subcommittee that is looking at managed care, all of these things, because we are not addressing it anywhere. And that's a piece that keeps falling out. So I don't think, I thought about putting it over there because I put programs, but then if you look at it, it doesn't exactly fit there. And so I think, Karen, if she could pull that and we could do that separate, that would give us an opportunity to really start pulling all of that together and have a focus on it, and not just thinking, okay, you know how I feel about a connection program. Nobody has owned it. So that would give it a home. That's where I'm thinking it goes. I don't think it goes here, and I think I want to separate it from planning and let planning deal with the bond and facility. That's, if we keep those two going on this other one, I think we could get better. And okay, that's how I'm thinking about it. Karen, are you?
No, I mean, you and I had this conversation yesterday because we had these same concerns, kind of where is this coming up? How is it? We're evaluating it. And it does align with the 3 priorities that we set up for next year, which was under patient access and trying to determine kind of what services we need. I would see this as kind of what are the services we need and how is it that we're going to contract those services, whether it's internal or external. And I think that committee that's set up with a couple board members on it will help give us direction and keep our work focused.
Okay.
That's one of the reasons why I asked for that. I was going to volunteer a chair of planning, but
That's usually the way we do it. If you're not here, you get assigned.
So for the combined income statement, you can see that from an operating margin, JPS is at $40.2 million. We had budgeted to be at 51.6. Although, again, most of that is driven by the salary escalation cost and staffing shortages. I will say that we have been able to hold on some of the discretionary spending, although that's not something that we've been able to make up 100%. Salaries and benefits is well over 60% if you exclude the depreciation of our total expenses. So we have made up some of that, but I don't expect us to be back to budget within the next 2 months. I don't see any change in that. We talked about that in the budget presentations. Are there any questions through July that I can answer for you? Okay, I would just ask approval for the unaudited financials for July.
Second. All in favor? Opposed? Motion pass. Next item, please.
So, I'm sorry. The next item on the agenda is the approval of our annual contribution to the defined benefit plan. You have several reports that have been attached on your portal. I've taken the liberty to pull out about 6 or 7 numbers that I think are most meaningful from those reports. This is right on the same funding that we did for last year. Last year, I believe the funding request was for $20.1 million. So, and I will say that the expense that you see on the income statement is calculated a totally different way than our cash contribution is calculated under the accounting standards. So we contribute about 6.25% of employee salary that participate over the year. And the actuarial liability amortization period is one sign of the health of a pension. The Pension Review Board allows this to be up to 25 years. So what that's telling you is if there's not any other changes in the market, which there will be, that it would take us about another 2 years of like contributions to fully fund that amortization period. It does vary year to year. We usually range somewhere between 2 and 6 years, given the market conditions. Right now, we have a little over 6,200 participants, and 4,100 of those are actively contributing to the plan. There's 2 other numbers, but I think the interesting number is the planned fiduciary net position, which is 108%. That is the number that you typically see in the newspaper as it's reported. It's a complicated calculation, but anything over 100 is extremely healthy. Again, market conditions will drive this, and it might swing 15% one way or the other. And given the impact that we had last year and the growth of our assets, I think this is the first time that I've seen it over 100%. With the market conditions that have happened over the last 12 months, and this is looking at the beginning of the year. So when we do this next year, I would expect that 108 to fall due to some of the market losses that we've had in the plan. So, but it's a very healthy number. Sometimes you might hear 60% funded, et cetera. So just know that we do fund our plan annually, and it is healthy. So I'm requesting a cash transfer to our pension of $20.425 million to meet the needs of the Pension Review Board.
Any discussion, any question before we move for approval?
This is just our regular pension, right, that we do every year?
Yes,
Okay,
ma'am.
I'll move approval of that one.
Second.
Oh, I think I'm supposed to abstain from that since I'm
Abstain.
I'm a part of that pension.
But you can
plan.
move the motion.
Second.
By Ralph, all in favor? And opposed? And we have one
One
abstain. Or would you like to add more to that fund?
Yeah, I would.
I'm very popular.
Right, next item.
Mr. Chairman, I believe we're
tabled
going to move
the-
C to a later discussion.
Right, we're going to move that to closed session. Item E.
We're on item D for the,
Insurance policy.
I'm sorry.
I'll move these for you, Daphne.
I do it. So
I need glasses. Sorry.
So do I. This is not good at all. It is time for our insurance policy renewals, and consistent with prior discussions with the board, we are exploring other opportunities. We knew we wouldn't likely be able to move forward with any of those this year, but I did want to update on some of the work that we're doing to try to figure out what makes the most sense for the hospital district. I'm not going to spend a lot of time on these slides. We've brought these forward before. It just kind of shows what we're doing along the lines of comparisons. This first slide just shows some of the pros relative to the various ways that we can protect against the risks that are anticipated in connection with each of our insurance premium coverages. And so we've got traditional insurance, which of course, except from the cost perspective, has the longest list of pros for us. The captive is something we've talked about. We've continued to try to get smarter about that, and we had discussed with the board kind of some preliminary costs associated with moving forward with a captive manager that could help do some more of the work. But we've also moved into a deeper exploration along the lines of the notion of a self-insured trust. And that is not new territory for the hospital district, because as we've begun to explore that further, we did discover that we have had those in the past, and we may have one that's still active now, but I don't have all of the information relevant to that, so that's just kind of a high-level overview. And this slide, the next slide just kind of shows some of the cons relative to each, just so that as we're thinking about this, we can, as we decide that one opportunity makes more sense than the other, we can delve into this deeper to make sure that we fully vetted, what the downside of a particular approach might be. We've talked about, again, with traditional insurances, we're continuing to see these premium hikes, which is what sent us down this path of exploration in the first place. We have very little influence over what those will be, and they are looking more broadly from the market. As we will see some of the trends, we continue to get higher premiums even for lines that we're not accessing, so it's not a kind of an individual assessment to kind of keep that premium lower. Again, with the captive, we would experience some higher startup costs. I think I mentioned to the board before that we wouldn't be able to just take all of these lines because we wouldn't want to take on all that risk in the captive, in the early on years, so it would take, more of a ramp. And then trust, we might have we might have difficulty in accessing certain markets of insurance to help protect us there, and the types of risks that we could insulate ourselves from in the trusts are maybe limited.
Daphne, do we have somebody helping us with this?
Yes, we do. We have a consultant. We've been having conversations with our fiduciary, and we will get of course, outside legal counsel on both the trust and the captive model as we continue through the evaluation.
Is there a time frame that you have in mind where you'd have a recommendation ready?
That's a little bit tougher. I think that our goal is to, by the first of the year, at least have vetted more of those two options.
Escape.
From the insurance perspective, we won't, and that's why we're trying to see if there's a way that we can take on some of that risk ourselves with, and this slide kind of demonstrates it with the amount of premiums that we're paying, and they've steadily increased over the years, and you all have seen this slide before, and when you, relative to the claim recoveries that we've gotten, of course, this doesn't count, some of the money that we already have to pay out of pocket anyway to even get that recovery. It's, we're throwing a lot of money towards premiums that we're not able to get back. And even in the two years where we had higher claim recoveries, those were sort of anomalies. We had, significant property damage relevant to the storms. And then we had one of our workers' comp claims hit in one of those years. So that's not, if you bore this out over a longer period of time, you would see that not very little in claims, but still these ever-increasing premiums.
I have a question for you. I'm not sure if it's appropriate in here or not. As we look at the insurance, should we be looking at the insurance that our vendor provide to us to see if it's adequate also as well?
To tell me what you're saying.
For vendors that's selling stuff to us, right? Do we need to we look at that to see if they have enough coverage going forward?
Oh, correct. So when we enter into contracts with our vendors, we do require them to have a certain amount of coverage. Where we've been challenged is with vendors that provide some of the riskier services to us. They have pretty much been shifting that risk, and so it's causing us to feel like we have to be more insured in certain of those areas. And this actually is the last slide for the open session. I was going to request to go into close to actually discuss some of the quotes that we've gotten back so that we can answer more questions about those.
All on separate terms in terms of the timing that we would have to, the window that would be open for us to make a change?
Unfortunately, what you've seen is that every year we come in the same month, and so usually those those coverages are renewing at the end of September. So we're usually bringing it now.
Okay.
And all of those lines, would expire.
So we're not going to have a change recommended from the traditional plan for 2020, 22, 23, but maybe 23, 24.
Correct.
We'd be looking at potentially.
Correct.
changing.
And we do have some discussion around, based on the amount of coverage that we've taken out in some of those lines, maybe there's some different things that we can do to kind of decrease those premiums.
Okay.
And then once we have that discussion, we will come back out to request approval of our premium amount that we'll have to pay for this year.
Okay, thanks.
Okay. Next item is item E, for consideration approval for nurse direct placement agreement. Do we have pronounce your name.
That's okay.
Welcome.
Sounds like Godiva.
Hi.
Yes. Good morning, everybody. Again, Carla Coiva, I'm Chief HR Officer. I'm here to ask for approval of nurse direct placement agreement and temporary nursing staffing agreement between AYA and the hospital district. The annual cost is already included in the approved fiscal year 22 operational budget.
May I have motion for approval?
Second.
Any discussion? If none, all in favor?
Aye.
Opposed? Motion passed. Thank you.
Thank you.
And item F, Ms. Joy Parker, welcome.
All right, good morning. Got a few contracts here for your consideration. So the first one is, again, as a follow-up to our MRI master plan project. It allows us to lock in pricing to secure a new spec CT unit for our main campus as part of that master plan. And so this is a part of that construction multi-phase, multi-year MRI master plan project. Any questions on that one?
Is this part of are they part of the GPO also as well?
Yes, and I apologize. Siemens is on Vizient, yes.
GPO, okay. Any discussion? If not, a motion to approve?
Move approval.
Second.
All in favor? Opposed? None. Motion passed. Next one, please.
Right. The next contract here is an amendment, a third amendment to our professional services agreement with HHS, which is our environmental services team here at the organization. This allows us a little extra time to finish up the RFP process. That RFP actually has been posted and closed. We have some respondents, and so we'll begin vetting through that. This allows us that coverage to maintain through the remainder of the year. In addition, it approves the coverage for a facility engineer that supports maintenance and repairs to our equipment within the textile area, which has been very helpful.
Any discussion, question? If not, motion for approval.
Move to approve.
Second.
All in favor?
Aye.
All opposed? Motion passed. Thank you. Next one, please.
This next one, as I looked at Dr. Miles over here to my left, she has pom-poms out for this one for sure. But this provides us to purchase reagent for our ID Now, which is our rapid testing platform that we use for COVID-19. This is an exemption to bid because the reagent is proprietary to the Abbott ID Now, but we try to maintain adequate stock, and so this allows us to have that readily available.
And this will cover the, whatever the
Monkeypox.
no.
That's a different testing, but I got that next. DT.
Just trying to help.
The latest one out there, what is that?
Oh, the variant, you're talking about
The variant.
Oh,
different
that-
variant.
Oh, yes, the
COVID
variant.
variant,
You know,
okay.
Dr. Miles, I don't know if you want to comment to that, but
It does detect variant, and it has this contract has no minimum volume requirement, so it allows us to purchase reagents as needed. So if we get into another surge, heaven forbid, we can ramp up more quickly.
Okay, sounds good.
Right.
Maintain motion for approval.
Move approval.
Any second? Second by Amanda. Motion. All in favor?
Aye.
Opposed? Motion passed. The next one, Ms. Parker.
all right. The next one is to consider approval of an interlocal agreement. As monkeypox came on the scene as another, yes, I see Dorothy's head nodding here. Public Health, we are great partners with them, and so they reached out to ask in preparation that we would have an agreement that would help support, if needed, a testing resource. They do have a lab on site, but they have limited capabilities on that. So this allows kind of a backup to that, and we would support public health in this effort if called upon to help with testing. And so it's a reimbursement to us for the cost of the test and the labor to perform the testing.
Entertain motion for approval.
Move approval.
Second by Ralph. All in favor?
Aye.
Opposed? None. Motion passed. Before you go to the next one, I just want to remind the last one carried the
I know,
the bidding.
it was an exemption, forgot, but it was an exemption. I was making the motion to approve the exemption and the contract.
Item J, please.
Right. And this last one that I'm bringing forward is consider approval of a pricing agreement between Acumed and the district. This provides hand implants and supplies that meet our standard of care. Through the RFP process, this is one of the 3 vendors that were selected out of that 5. And so it aligns with our goals to reduce operational cost and improve patient safety through the standardization of these implants and supplies. And let's see. Estimated possible savings of $12,000 per year.
Any question for Joy? If not, may I have a motion for approval?
Second.
Second. All in favor?
Aye.
Motion pass. I think the next, thank you, Joy. Appreciate it.
Thank you.
Good morning, Mr. McCarty.
Hi, good morning. Just as a quick reminder, many of the managed care agreements roll up through revenue cycle. Have a couple of those today to go over with you. This first one, item K, is Cigna Behavioral Health. Best way I know to describe this, you have Cigna as a parent company, and then you have behavioral health. They're 2 distinct entities. The Medicare Advantage portion of that was still under the parent company, and we're simply moving that to the behavioral health agreement. There's no financial impact to JPS. It's positive. We can negotiate separately in instances when we need to, so I would request your approval on that.
So this is the reassignment over to the other
Correct.
side? Motion for approval? Second. All in favor? Aye. Opposed? Motion pass. Next
All
one,
right.
please.
Item K, Trent alluded to this earlier. This is one of those agreements that Cook Children's is formalizing the payment directive through HHSC. So we're just simply amending our current agreement to authorize them to pay that additional CHIRP reimbursement.
Okay. Second.
All in favor?
Aye.
Opposed? Motion pass. Next one. Thank you. Dr. Elliott, how are you?
Good, thank you. Good morning.
Good morning.
So thank you for the opportunity. We are asking for approval of an exemption to bid for our First Amendment to the Master Agreement of our Caius agreement for Tarrant County Hospital District. As you know, we have centralized our grant office with sponsored programs. We want to make ourselves highly efficient in doing this work. And so we want to make sure we add this component to our Caius grant management software, which will include the fund manager module component of this. This is already budgeted in our FY22 budget and in FY23 also, so asking for approval for exemption to bid.
Any discussion for this item? If not, entertain motion for approval.
Move approval of the exemption to a bid and the approval of the amendment. Okay.
Let's put the exemption to bid also as well.
Yeah.
Second by Dr. Rob. All in favor?
Aye.
None? Motion carry. Thank you.
Thank you.
Next item is item N. Hello, how are you? Welcome to our committee.
Good morning. I'm Will Showalter, Chief Information Officer.
Yes, sir.
And I'm here this morning to seek approval for the Master Software and Services Agreement for 3M Health Information Systems. If you're not aware, 3M is the backbone of our medical coding software. There are 4 components to it. There is the Encompass 360, which is the computer-assisted coding, which is the actual software that translates MedRecords data elements into building codes, ICD-9, DRGs, et cetera, et cetera. There is the 3M Clinical Documentation Integrity System, which is the tool that provides financial review, quality metrics, clinical validity and risk tools. We purchase a series of information contexts such as groupers, geographic adjustment data files, et cetera. And then in this contract is also M-Modal or Fluency Direct, which is our voice recognition and speech dictation software. We're asking for approval of this. This is the incumbent software. We have a contract with them back to 2015, June of 2015. We'll be looking for a 8-year potential contract, 3-year term with 5 years on a yearly renewal, capped at 3% growth each year. And then we will be looking to do an RFP in 3 years from now.
And this is the 8-year contract, right?
I'm sorry?
8-year contract?
Yes, sir.
I went through with this one, and I usually don't like anything over 5.
I know, that's what I was
But the
gonna
challenge
ask.
is that we're so embedded with them, it's very costly to unwind. So I would highly recommend taking that into consideration.
Okay, that was my question. Okay, thank you. Then I recommend approval.
Not disruption if you don't. Any second by Ralph?
Thank you.
All in favor?
Aye.
Opposed? Motion passed. Thank you. Item O. Hi, Wanda. How are you?
Hi there.
Good morning. I'm here this morning to ask you consideration for approval for an exemption to bid for workplace violence assessment and service agreement for the work amendment to the master service agreement between Vizient and Tarrant County Hospital District. It is for $107,000, which is included in the 2022 budget. This exception is being requested due to given the recent active shooter events that have occurred in healthcare across the country and even close to home here. And Vizient has on their team some team members that are considered experts in their field across the country. They actually make the videos that hospitals use to teach about active shooter. So we are requesting to bring them in to do a risk assessment and to look at our vulnerabilities.
All right.
This one is one of those that I thought we may ask our general counsel to update the procedure or somehow, because it should fall under the guidance of the CEO, and we might not need to approve this in the future. So it's one of those things.
Right, it's
Service
just
and
because
more
of the
service.
exemption. to
Right, the bid and all that
Okay.
stuff.
All right.
But I highly recommend we come up with a procedure for that or something. Any question for this? If not, entertain motion with the bid exemption also as well.
All right. Move approval of the exemption to the bid and for the agreement. Okay.
Second by Zim. And all in favor?
Aye.
Opposed? None. Motion passed. Thank you. You have any?
And maybe I just woke up at 2 a.m. thinking this would be nice, and I dreamed it, but I don't think so. Wasn't there a discussion this past couple of weeks with the county about transferring from our budget to theirs some of the components of the existing jail agreement and public health services that were coming out of our budget today?
Yeah, it was just public health. That was part of that discussion as to whether public health would continue to contract with JPS for those services or whether that would be a direct oversight by the court itself. So there was some discussion. There was no decision made around that.
So our budget still, because that would have a budget impact, would it not?
It would have a budget impact to the bottom line.
But we
yes.
don't know because the court hadn't decided yet?
They have not decided, and so there's still some conversation. In fact, I had conversation with Commissioner Johnson yesterday, and that came through, so there still is not agreement in the court as to when to do it. I think there is consensus that it makes sense from their standpoint. It's just the timing on it.
Certainly would be nice.
I know, and if you can, no.
Interesting to bring that up off the record.
And if we need to, they can. I just don't know if it's eligible for closed session discussion.
Well, yeah, because I received a call from a person that is asking, is there a official agreement and procedures for JPS in jail. I don't know why the question was asked, but I wouldn't respond. Do we have policy and procedures on our responsibility versus the county and the jail?
I think we should move that to closed session, if you don't mind. Okay. Anything from planning, Trent? No?
We'll have a steering
Okay.
committee meeting in September, so we're good for now.
Yes, sir. I think we're going to go, we are going to go into, convene into closed session at 10:55, 57. Thank you. This time, we're going to go back to our regular session. And go ahead.
Yes, Mr. Chair, thank you. I am requesting approval of up to $2,315,796 for payment of our 2022 to 2023 insurance premiums.
May I have a motion to approve? Second by?
Second.
All in favor?
Aye.
Any opposed? None. Motion passed. And that will conclude our Finance Committee for this month. Thank you so much for being here.
Hi, we're going to call to order today's Human Resources Committee meeting. Are there any citizens wishing to address the committee? There are no citizens. Meeting, we'll move to the third of approval of minutes. Do I have an approval of the previous minutes?
Move approval of the minutes.
Second. Any discussion? Yay, nay? Yay?
Aye.
Okay. All right, all in favor?
Aye.
All right, meeting passes. Next portion we have is an update from our Director of Human Relations. Carla?
Hello. Hello. There we go. Thanks for having me again. It's my pleasure to present to the Board of Managers on some of our human resources update. I've been here 6 months in a couple of weeks, and I just have to say that it's been such a joy being here. I've really enjoyed working with our team, our physicians, and I just love getting to know everyone, and I just want to thank you all for, again, giving me this opportunity to be here. As you all know, human resources has been challenging in the past few years, especially when it comes to recruiting and retaining talent. And so I'd like to give you a view on where we are in relation to the Great Resignation. And unfortunately, data is continuing to show us through research, surveys, even our own experiences in JPS that this exodus is not quite over. And as an organization, we do have to gear up for what does that mean for JPS and what is our strategy and our plans moving forward to focus on recruitment and retention. As you can see on this slide, we are expecting, or at least the healthcare industry is expecting, a huge number of healthcare workers leaving their roles and also leaving their profession. And they are leaving for a variety of reasons. And as you know, back in the day, we would always focus on relationship with the manager, building a really amazing work environment. In this day and age, they are leaving for multiple reasons. Pay and benefits continue to be a challenge. There's still this, what I'm calling the urban legend, that other hospitals are paying more, paying less. True or indifferent, they are leaving for pay and benefits as well. But they're also leaving for personal reasons, such as just looking for a change, just being exhausted. And so we have to address that as an organization as well. I want to go over how this translates to JPS. This is what we're seeing in the healthcare industry. But as far as JPS is concerned, you saw the slide during the budget retreat. As you can see here, this is how the Great Resignation translates to a higher labor cost for JPS, primarily in contract labor. That is really where our biggest opportunity is. Our goal, of course, continues to be strengthening our recruitment and retention efforts to ultimately reduce contract labor, and that is where HR is focusing a lot of our efforts on. So this is the financial view of our recruitment and retention. I'd like to share with you what this looks like from a workforce perspective. And as you can see here on this next slide, while the total headcount has not really increased drastically year over year, what you're seeing increase is the number of contractors we have at JPS. 2022, as of July of this year, we are sitting at 16% of contractors as far as our total workforce is concerned. And again, that translates to the right side of the slide, our vacancy rate, where we have over 800 open vacancies. It's high, but this is the same as any other hospital out there. So this is not really just a view of JPS, it's a view of most healthcare organizations. And so our focus is in the recruitment space. And I'd like to share with you what departments and what positions we are focusing on. So as far as departments, as you can see here, mostly clinical roles, but really anybody in the clinical support space. We are looking for nurses in multiple units, but we are also in need of patient safety assistants. We are also in need of respiratory therapists, pharmacy techs. So we are looking at the overall patient care arena. But as far as we're concerned here at JPS, these are the areas, departments, and the positions that we're focusing on. So essentially, we really just need to get employees in the door, right? And we are looking at what does that look like for JPS to attract talent.
But Carla, a quick question on
Yes.
vacancies. How did this reflect prior to COVID? Are we seeing similar departments and similar needs, or are there separate needs?
Similarly, but just not in the same number that we're experiencing now. These are the higher acuity departments, and so that's where we're seeing more burnouts. If you think about it from a throughput perspective, patients going into the ER, into the ICU, into the OR, being cared for by respiratory therapy, then downgraded to med-surg. It's really the throughput. And the numbers just seem to be higher, but similar needs year over year.
Thank you.
You're welcome.
Carla, similar
Yes.
question. Do you have any data that you might be able to share with us regarding what the vacancies are among the clinicians and the physicians?
From a clinician, from a nurse perspective, I'll tell you we have over 40 open vacancies in the ER currently. As far as providers, I am not able to answer that question, Dr. Haynes.
That vacancy in the nursing area in ER, that's a scary point because
Sure.
they eventually going to become burnt out, then it's going to be a greater.
I completely agree with you, Reverend. That's why we're seeing more contractors in ER as well to really address that aspect.
Yeah.
Yes, sir.
Are we paying them, should we start looking at that side of it too?
Say that again. Are we paying?
Looking at, because somebody's paying them a lot more, plus markup that we paying also as well, right? Because they have to have at least 30 to 40% markup.
That's very true. So I will say that in 2020 and 2021, the increase in rates of our contractors was astronomical, right? But we are seeing reduction in rates now. About 20 to 30% of contract labor is actually starting to go down. But again, the strategy for us is we need to hire more regular employees to reduce the number of contractors across the network.
Let me ask you this, is there a legal way? When, I'm not going to mention when, but when I was with other company.
Say that again, DT.
Back in the, when I was very active in other company, we have a provision with our staffing company, whereas as they staff our people, they're not allowed to hire our people away.
Oh, yes.
Because all they do is just roll it to the other side.
That's right.
And that is a challenge that we have, and we were able to do that. Is there anything that we can do?
You mean put language in the contract that prevents them from recruiting our employees? Yes, and we typically have that in there. It's about how you argue. I mean, you can't obviously have like no poach arrangements, but
Correct.
it's a mechanism of whether or not they're actively recruiting them or if they're just going voluntarily.
Generally speaking, our commitment with contract agencies is about 16 weeks. And at that point, that's the time that we legally cannot convert them to full-time because they're dedicated to us contractually for 16 weeks. However, at the point where employees are ready to either continue their contract with another hospital or convert to full-time, they tend to initiate that conversation with us. As long as they've completed their commitment, we have the ability to convert them to full-time. In fact, contract agencies, that's really a part of their value proposition, that we will give you the talent, and you get to have them once they complete the commitment. And that's definitely a strategy that we are also using. Yeah.
Are the contracting rates going down?
Say that again?
Are the contracting rates going down?
They are. Because there's just not a whole lot of needs for, the contractors' needs are actually going down, generally speaking. And hospitals are making a stance that they're not going to pay that much anymore, and so candidates sometimes have a smaller pool of choices. Unlike during the pandemic, they could really go anywhere they wanted to. Yeah. Thank you. So moving on, again, talking, yes, sorry.
No, I was just going to add to that, Carla is correct, fewer surges. And so as a result, they're not having to staff up, there's this periodic staffing up and you had to get it in quickly. And as you've noticed, I don't know the last time we've talked about a surge. And so a lot of that is that there's just not as much demand for needing contract help as much or as quickly having to staff up.
Yeah.
And I think that's happening all over. That surge is going down all over, so
Yes,
they
ma'am.
can't just jump around like they used to. Yeah.
Yes, ma'am. Yes, ma'am. So again, going back to what this means for us from a full package perspective, that's really how we need to look at recruitment and retention. Because of the data that we continue to see and analyze, people are not necessarily leaving or staying for a couple of reasons. They're staying and leaving for multiple reasons. And so if you look at our pay rates and living wage, our goal is to ensure that we're staying or maintaining competitiveness. We're not trying to one-up any other organization because, again, we know that it's about the full package. So, but it behooves us to really assess the effectiveness of our pay rates, and primarily in the clinical areas where it's harder to staff, and also assessing our living wage to make sure that we're not losing frontline workers that are also essential in our operations.
Can I ask a question?
Yes, sir.
Probably politically incorrect, but I believe we have a policy that says if you're not vaccinated, you can't work here. And I'm curious, number one, how many people have we terminated because of that, and particularly in the area of nursing? And have we thought about going back and reviewing that stance based on the information that's available now?
So Daphne may be able to speak to that, but remember, as far as the definition of mandatory is that you either receive the vaccine or that you have submitted for exemption, and that has been reviewed. With that said, we did have a number with the COVID vaccine, and year to year with the flu vaccine, we have fewer that actually apply for exemption. And so I would say that our number that we actually terminate based on that mandatory requirement is very low. But Daphne, I'll let you, because you've been working closely with that
Yeah,
number.
that's accurate. We actually go through a process, and then for those individuals that can't comply. And just as a reminder, the requirement related to the COVID vaccine related to a mandate from CMS, and so that was something that we felt like we had to comply with. But the numbers that we weren't able to either work through that exemption process or figure out how we were going to get them vaccinated was very low.
Well, the reason I asked the question is I know with our military now that there are huge numbers of military that are getting out of the service, and yet we're having more and more trouble doing what we're asking our military to do, and I just wondered if we were somewhat in the same boat.
Yeah, here you go. Thank you. So moving on, when it comes to leadership development, this is a huge ask by our workforce. You know, they miss being around their peers. They miss continuing to learn. So we are in the midst of revamping our programs, focusing on responsive and reliable courses. And what I mean by that is some of the competencies that we used to promote, you know, pre-COVID, we're assessing whether or not those things are still relevant to us. And so we are focusing on, again, responsive and reliable courses so that we don't go into a classroom and what I call spray and pray. You just, you know, spray them with a lot of knowledge and then you pray that they get exactly what they should get out of that. And so we have a team that's currently revamping that, and we hope to introduce that to you at the next HR board meeting. And just to kind of build up on that, you know, there are 3 areas that our workforce is asking for is how do we build a better relationship with our supervisors and vice versa? How can I as a leader be more connected to my employees? And they're asking for help on that. And just having some career pathways and more opportunities to learn, be it, you know, a standalone course on emotional intelligence, for example, or a full cohort of learning on how to be a leader. So the voice of our customers to me is really important. I've been hosting a lot of what I call Coffee with Carla, where I have employees attend a session with coffee with me, and I just ask them, what is your experience when it comes to, as an employee here at JPS? Tell me more about that. And it's been received really well. We host about 2 a month, and we get asked to go to certain departments as well. So we're continuing to gather the voice of our customers through those forums, but we also have surveys. And as you all know, we are gearing up for the employee engagement survey, which I will speak more about. And that's also another data point for us to use. Again, it's important that our workforce has a voice in somewhat dictating the strategy for HR. Diversity, equity, inclusion, and belonging is another huge strategy for JPS, and we are in the middle of our self-expression survey, which will end at the end of the month. And once that's done, we'll be able to analyze our workforce, the landscape of our workforce, to understand where our opportunities are and what our jumping off point looks like from a development of employee resource groups, training for employees, training for leaders. So really what this is strategy development. And I talk about this full package, but this really becomes a part of our recruiting efforts. This is the story that we tell to our potential candidates and the people that we're trying to attract. But at the same time, our package is just as good as talent availability, right? So I'd like to speak to you regarding where we are attracting talent. As you know, there is intense competition in the DFW area. We are attracting the same pool of candidates, and so we need to consider what it means for us to recruit outside of Tarrant County and even outside of Texas. This is something that a lot of healthcare systems have been doing for years and years. From an international recruitment perspective, I'd like to highlight that foreign-born nurses make up the 1/6 of U.S. nursing workforce. And so this is another area that we need to consider to ensure that we have a long-term sustainability solution to manage our workforce and ultimately continue the service that we provide to our patients. And also strengthening our RN residency program university partnerships. So we are exploring those options now and hope to be able to provide more of a concrete recommendations to you all.
I believe in 2019, 2 nurses that were foreign celebrated their 40th year here at JPS. Well, right.
Yeah.
I'm not familiar with 6 of the U.S. nursing workforce.
Makes up a 6th of the work. 1/6.
1/6.
Okay.
And we could talk about outside of the hospital structure or about the environment, what can be provided, cost of living and that. But that's almost null and void now.
Good point.
I was here when they brought in the international nurses. And what that meant is when they came in, we did have to provide apartments and transportation until they got acclimated. And so it was successful. I think I was here with the nurses that came on then. But it's a heavy lift on the organization because it's a little bit more than just saying I'm hiring them, because when they get here, it was having apartments
That's
for
right.
them, made sure that they
Acclimation
was
period.
safe
Yes,
to
ma'am.
get there. Yeah.
Yes, ma'am.
Culture.
Culture
Yeah.
integration, correct.
Yeah.
Yeah, this is a space that I actually worked in for 9 months as a consultant, so I understand the complexity of onboarding international nurses, and really anybody for that matter, right? It's buying a car, getting an apartment, getting a bank account, and those things, and that needs to be guided, right? And as far as our recruiters are concerned, I am placing dedicated recruiters to what I've shared with you as hard-to-fill nursing areas, primarily in ED, critical care, peri-op, women's behavioral health, and respiratory, to ensure that we're spending 70% of our time focusing on clinical positions.
Is there a test or license that they have to have for equivalent?
They have to pass the NCLEX, and then they have to pass the English proficiency test, and they have to show proof of competency in the specific nursing area that they will be joining. So their onboarding is a little longer because there is a certain switch to, like, Western medicine. But again, the solution has been available since the 80s when we had the influx of nursing internationally, as Dorothy explained.
Good experience. We learned to bring at least 2 to 4, same, so they had support. So it lasted, a lot of them stayed for a long time.
Oh, yes, absolutely. It's amazing when you create a buddy system for them, so they have a go-to person that's gone through the same experience. And ultimately, I'll tell you, it's a realization of the American dream for them. And so they, a lot of foreign nurses, they're the ones working night shifts. They're the ones picking up overtime because they just absolutely love the opportunity that's provided to them.
I guess we can, once you develop, we probably know more, but is there a need to have a better introduction to bedside manner? Because foreign country may view patient care differently than what we used to, especially a lot of stuff has to do with survey and all that stuff for us also as well, so.
Yes. Yeah, that's another.
I'm a little bit concerned about long-term effect because of bedside manner type thing.
But that's all part of that. When they come on, you work with them, and there was a special training, and at different countries, you know how to address that. And so that's all part of that onboarding. And because some of the countries, they didn't believe in medication, so that was a big deal for us, for them to work on the surgery floor, so we had to address that. So that's all part of that onboarding. You have to get to know what their culture, and then educate them on the stuff that how we do it. And it was not a hard transition, I'm telling you. It was.
I don't think I can add any more to that.
Dorothy, I remember, and this was in the late 80s, when and we had nurses come from Ireland, we have them come from all parts of Europe, Africa, even Asia, all over, and having that diversity, but it was really a good experience, I think, and also the differences in the work ethic, the differences in the culture, but it was a really I think good thing, because it introduced us as clinicians to new ways of thinking as well. So, I would highly encourage we look at that.
Yeah. My experience has been it's such an amazing culture add to the organization, to have different cultures really merge and share that with one another. I mean, my favorite was just having the potlucks.
Holidays were wonderful.
And holidays, exactly. Exactly. This is a good segue to our diversity, equity, inclusion, and belonging journey, right? So as you know, we have this partnership with Caius in the midst of our self-expression survey, and the executive team actually went through a learning journey a couple of weeks ago, which was well received by everyone, and we will continue to do that. But we would also want, our board of managers, our directors and managers to go through a different set of learning journeys, so we all constantly stay aligned in our path forward. And then in the future, we will be holding more gap analysis work to ensure that our policies and procedures, such as recruitment, retention, promotion, are inclusive in nature. So I'm excited for that work as well. Internally, we also have a DEIB committee that we've put together between myself, some members of our executive team, and Dr. Elliott. So we're going to use and train this team as well to be the voice of DEIB for JPS, where they are helping us manage the communication loop between employees and leaders, and also help with developing and promoting our DEIB events. At the end of the day, diversity is really lived through our daily employee experiences, and we want to make sure that this just becomes embedded in our culture and it's no longer a strategy. Employee engagement survey will happen in September, and as a reminder, this is going to be our second year with Gallup. And we ended last year with a 4.04 score, and our goal for this year, stretch of course, is 4.19. And we're also going to be promoting a higher participation rate this year. We have 2 weeks long of encouraging our employees to participate, and we have some events scheduled to make sure that we touch every single employee. And again, as a reminder, based on our last survey, we have some core opportunities, recognition, my opinion matters, and I get feedback on my progress as an employee. So we have been focusing on those 3 areas as well, working with our leaders. New benefits that we're going to be offering for fiscal year 23. So we heard our employees. We don't have a total solution because that requires a lot of analysis, but I think this is truly step in the right direction. We are going to be offering WeCare. This is a home-based childcare, so as opposed to a daycare center, there are plenty of homes in the community that have been vetted by the state state, by the county, by the city, and by WeCare, that they meet certain criteria and they go through certain licensing, training, compliance. The benefit to our employees is that they would receive a 20 to 40% discount as an employee of JPS, and JPS being a member of the WeCare community. So we are promoting this during our open enrollment. We're going to have a benefits fair next month, and also we're going to communicate this and promote it by email and many different mediums as well. Another offering that we will be extending to our employees is what we call ComPsych, additional emotional support from an EAP perspective, legal guidance, financial resources that our employees have also been asking about. As far as analytics, we offer two different types of medical plans. So it's HSA and the PPO. We are partnering with a company called TBX, and what it is, it's a decision tool where it's an interactive tool where employees are able to enter their family makeup, a series of questions that they ask, and the tool will show them what the best plan that they need to really be signing up for. So it's very interactive. It's a lot of educational tools that will really allow our employees to make the right decision for their family. Okay. That's all I have for everyone. Any questions, feedback? Can I hire international nurses now? Just kidding.
So, in the report, it shows basically two KPIs, and they're both related to employee engagement. I'm curious, and this is probably just out there but not in the report, what are the overall HR performance metrics, specifically when we're talking about transitioning people from contract to full-time employees and then full-time employee retainage? Because I would like to see something that shows me what we're trying to accomplish specifically, and I'd like to see the numbers that ultimately will track that.
Sounds good. I will absolutely provide that to you at our next session. But just to kind of speak on it, we are tracking what we're calling conversion rate, right? From contractors to full-time, how many of those employees are staying and how many of them are leaving? And also, not just the contractors, the ones that are considered PRNs or temporary, seasonal, we're also talking to those employees to join us permanently, and we are able to track that, sir.
Great, that would be helpful.
Absolutely.
Yeah, Carla's not giving herself enough credit. She actually has hired an HRIS person who is going through, as you can imagine, with all the different systems, the data was just not flowing correctly, was not always accurate. You could pretty much pull what you wanted to. They are working very hard behind the scenes, and so she did ask that she could bring that next time as they begin to clean up that data and create that HR dashboard for the board that aligns with our strategy and priorities.
Sounds good. Thank you all.
Can I ask what was the, Carla, do you remember what the participation rate was last year of employee engagement and clinician engagement? Do you know what the participation
I can speak for employee engagements. It was at 74% participation rate. Okay. Historically, from what I was told, the JPS could reach up to 90% participation rate, so we are very hopeful this year that that's going to be our goal.
I noticed that you wanted a greater than 80% participation rate.
In speaking with my team, I think we're going to target 90%.
Great.
Hefty goal.
Yes, and we do know that a lot of surveying is happening around employees, so we want to make sure that they don't have survey burnout also, because we know that that's a possibility as well. So, as much as we can. All right. Well, any other questions for Carla? And this was also in response to some of the things that we heard during the budget retreat on benefits. Carla's continuing to do amazing work in looking at what our other benefits can be offered to employees as we work through all of these different times. All right. Thank you, Carla. All right. Well, today we do not have any actions or policies to approve for this committee, and I don't have anything in executive session today. Yep. No. All righty. righty. Well, today was a short one. Please tell my other colleagues that it was a very short meeting. And as we go ahead and yes.
I know how that goes. This is the election.
Exactly. Yes, it's very true. All right, well, thank you. We're going to go ahead and adjourn for the day.